In this clinic series, we're taking a deep dive into hypertension or high blood pressure. Hi, I'm Dr. Song. I'm an internal medicine physician who started my own practice called HealthNet Clinic. So there are many types of hypertension. First is primary or essential hypertension, secondary hypertension, gestational hypertension, and also pulmonary hypertension. These are the types of hypertension that we'll be going over today. When we think about hypertension, we're talking about a chronic condition characterized by persistently elevated blood pressures. It is measured with a blood pressure monitor that measures two numbers. The top number, which is systolic, or a measure of how much the heart contracts, and the bottom number, which is diastolic, which is how much the heart relaxes. It can be measured at home with a home blood pressure monitor or in the clinic. Ambulatory blood pressure monitoring can confirm a diagnosis of hypertension by recording blood pressure over 24 hours. Sometimes clinicians offer ambulatory monitoring to patients who have white coat hypertension, which is hypertension that only is elevated in healthcare settings but normal at home, or masked hypertension, which is elevated blood pressure in general but normal blood pressure in healthcare settings. Home monitoring is usually preferred because office readings can be inconsistent. According to the American Heart Association, normal blood pressure is defined as a systolic pressure of less than 120 or diastolic of less than 80. Stage 1 hypertension is defined as between systolic of 130 to 139 and a diastolic between 80 to 89. Stage 2 hypertension is defined as a systolic blood pressure of greater than 140 or a diastolic pressure of greater than 90. Having too high blood pressure leads to damage to the arteries in the eyes, brain, heart, and kidneys, and can lead to myocardial infarction, stroke, and heart failure. Causes of essential hypertension are complex and may include genetic predisposition, endothelial dysfunction, and RAS system or renin-angiotensin-aldosterone system dysregulation. Risk factors include older age, obesity, a diet high in sodium or excessive alcohol, a family history of hypertension, being a certain ethnicity, or having a sedentary lifestyle. Your doctor may order imaging and laboratory studies to detect potential reversible causes of hypertension, detect additional risk factors and damage, and may include renal function testing, lipid panel, hemoglobin A1C, urinalysis, EKG, or echocardiogram. Symptoms are usually not present, but may include headache, dizziness, chest pain, and visual disturbances. To manage essential hypertension, these lifestyle modifications are recommended. Number 1, following the DASH diet, or dietary approaches to stop hypertension diet, which includes whole grains, fruits, vegetables, nuts, lean meats, and low-fat dairy or fat-free dairy, and less sugary drinks, snack foods, fatty items, and red meats. Number 2, weight loss to a BMI of 18 to 25. Number 3, physical activity of at least 30 minutes a day for 5 times a week. Number 4, reducing sodium intake to less than 2.3 grams per day. Number 5, limiting alcohol. And number 6, stopping smoking. Following these lifestyle changes may decrease your blood pressure by 5 to 10 millimeters of mercury. Pharmacological therapy is also recommended for stage 1 hypertension and includes thiazide diuretics, including hydrochlorothiazide and chlorthalidone. They increase sodium and water excretion by inhibiting reabsorption of sodium. They can also cause hypokalemia, hyperuricemia, and hyperglycemia. So they're good for patients with osteoporosis and calcium kidney stones, but bad for patients with diabetes and gout. ACE inhibitors such as lisinopril, captopril, and ramipril. They're good for diabetic nephropathy and heart failure, but they can cause cough and angioedema, which is severe or life-threatening. Angiotensin II receptor blockers, such as losartan, valsartan, or candesartan. They work similarly to ACE inhibitors, but they have less potential for cough or angioedema. Calcium channel blockers, such as amlodipine, nifedipine, verapamil, and diltiazem. They can cause constipation, bradycardia, or low heart rate, or peripheral edema or swelling in the legs. Beta blockers, such as atenolol, metoprolol, bisoprolol, and carvedilol. They're used in coronary artery disease, arrhythmias like atrial fibrillation, and during pregnancy. But they can also cause low heart rate and exacerbate asthma. MRAs, or mineralocorticoid receptor antagonists, such as spironolactone, are useful in heart failure. Centrally acting agents, such as clonidine or guanfacine, are used in refractory hypertension in dialysis patients. Sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors, such as empagliflozin or dapagliflozin, are used in type 2 diabetes, but also have a blood pressure lowering effect. A combination therapy of 2 or more agents may sometimes be required. Complications of hypertension include hypertensive emergencies, cardiovascular disease, kidney disease, retinopathy or eye disease, peripheral artery disease or limb disease, and diseases of the aorta. Screening for hypertension depends on your age. If you're between the ages of 18 to 39, you should get screened every 3 to 5 years. If you're over the age of 40, your blood pressure should be measured annually. Let's talk about secondary hypertension. Secondary hypertension is rarer and is defined as persistently elevated hypertension due to another medical condition or medication. Conditions include renal disease, endocrine disease, coarctation of the aorta, and obstructive sleep apnea. Medications include estrogens, corticosteroids, NSAIDs like ibuprofen, and decongestants, and also drugs such as amphetamines, marijuana, and cocaine. Features suggesting secondary hypertension versus primary hypertension include onset of age less than 30, uncontrolled hypertension despite being on 3 or more antihypertensive drugs, prominent symptoms, abrupt onset, and end organ damage. In renal disease, risk factors for developing renal disease include primary hypertension, diabetes, obesity, and smoking. Chronic kidney disease presents with peripheral edema, elevated serum creatinine, and protein leaking in urine. Ultrasound shows small kidneys. Treatment involves ACE inhibitors, ARBs, diuretics, and calcium channel blockers to help manage hypertension. Glomerulonephritis presents with hematuria or tea-colored urine. Urinalysis shows red blood cell casts, and serologic studies may show antibodies. Treatment is immunosuppression. Renal artery stenosis presents with narrowed renal arteries. You will hear an abdominal bruit. Doppler ultrasound shows poor flow in the renal arteries. Management includes revascularization with stenting or angioplasty. Complications include end-stage renal disease or persistent proteinuria. Hyperthyroidism and hypothyroidism are both causes of hypertension. In hyperthyroidism, patients present with palpitations, sweating, heat intolerance, weight loss, and lid lag. In hypothyroidism, patients present with cold intolerance, weight gain, and fatigue. Diagnosis is made with thyroid hormone testing. Hyperaldosteronism results from secretion of excess aldosterone. Patients present with hypertension, mild hypernatremia or elevated sodium, hypokalemia or low potassium, and metabolic alkalosis. Diagnosis is made with a plasma aldosterone concentration to plasma renin activity ratio of greater than 20 and confirmed with adrenal imaging. Management is with adrenalectomy or surgical resection or medications. Pheochromocytoma is an epinephrine norepinephrine secreting tumor of the adrenal medulla. Risk factors include MEN2B, von Hippel-Lindau disease, family history of pheochromocytoma, and age. Patients present with episodic hypertension, headache, tremors, sweating, and tachycardia. Diagnosis is with fractionated plasma metanephrines and imaging. Management is with adrenalectomy. Complications include cardiomyopathy and metastatic disease. Cushing syndrome results from excess glucocorticoids. Causes include adrenal adenoma or carcinoma, pituitary adenoma, and paraneoplastic disease. Patients present with central obesity, moon phases, and buffalo hump. Diagnosis is confirmed with elevated cortisol and ACTH levels, adrenal imaging, and pituitary imaging. Management is surgical resection, medical management, or radiation. Complications include osteoporosis and diabetes. Coarctation of the aorta is congenital narrowing of the aorta and may present in infancy, during childhood, or adulthood, depending on the degree of narrowing. Risk factors include bicuspid or aortic valve, Turner syndrome, or family history of coarctation. Patients present in infancy with severe stenosis or shock, and in adulthood with headaches, claudication, heart failure, or delayed femoral pulses. Diagnosis is made with echocardiogram, MRI, or CT angiography. Management is with surgical repair or angioplasty. Obstructive sleep apnea is intermittent hypoxia. Risk factors include male sex, middle age, neck circumference of greater than 17 inches in men and 16 inches in women, and obesity. Patients present with impaired concentration, daytime sleepiness, morning headaches, witnessed apneas, and snoring. Diagnosis is made with polysomnography or sleep study. Management is with continuous positive air rate pressure or CPAP therapy, oral appliances, weight loss, or uvulopalato-pharyngoplasty. Complications include cardiovascular disease, resistant hypertension, or pulmonary hypertension. In children, renal conditions like polycystic kidney disease, renal dysplasia, craniofacial abnormalities, stimulants or steroids, coarctation of the aorta, Cushing disease, or pheochromocytoma frequently cause hypertension. In pregnancy, hypertension is a spectrum of disease and includes gestational hypertension, preeclampsia, and HELLP syndrome. Risk factors include age greater than 35, BMI greater than 30, first pregnancy, diabetes, kidney disease, autoimmune conditions like lupus, history of preeclampsia, or family history of preeclampsia. In normal pregnancy, blood pressure is expected to decrease by 5 to 15 in the second trimester and returns to pre-pregnancy values by the third trimester. Diagnosis is made with new onset hypertension of systolic blood pressure greater than 140 or diastolic blood pressure greater than 90 after 20 weeks gestation, along with signs of end organ damage. Patients may present with headaches, right upper quadrant pain, visual disturbances, nausea, or vomiting. Labs may show protein in the urine, low platelets, elevated serum creatinine, or elevated liver enzymes. Monitoring for blood pressure labs and fetal well-being is indicated to monitor progression. Treatment is with blood pressure medications, including labetalol and nifedipine. Complications include fetal growth restriction, placental insufficiency, and fetal demise. Prognosis is varied, and patients are at an increased risk of chronic hypertension, diabetes, cardiovascular disease, and hyperlipidemia. Pulmonary hypertension refers to approximately 50 conditions that increase pressure in the pulmonary arteries. Pulmonary pressure refers to the pressure in the circulation between the right heart and the lungs. Pulmonary hypertension is defined as a mean pulmonary artery pressure of greater than or equal to 20 millimeters mercury. The higher pressure is caused by vasoconstriction and vascular remodeling. The WHO, or World Health Organization, classifies pulmonary hypertension into 5 groups. Number 1, pulmonary arterial hypertension, which results from direct injury to the pulmonary arteries. It can be caused from drugs like methamphetamine, infections like HIV, and autoimmune conditions like scleroderma. It is usually found in young females with no medical history. Number 2, left heart disease, which results from left heart failure or mitral valve disease. It is diagnosed in older patients with cardiovascular risk factors. Number 3, lung disease or chronic hypoxemia, which results from COPD, sleep apnea, obesity, hypoventilation, or living at high altitude. It is diagnosed in older patients who smoke, those with underlying lung disease, or abnormal spirometry. Number 4, chronic thromboembolism, which results from recurrent pulmonary emboli. It is diagnosed in older patients with history of blood clots. Number 5, unclear causes, including sarcoidosis, end-stage renal disease, sickle cell disease, and rare metabolic diseases like Gaucher. It is diagnosed in patients with history of major multisystem disease. It can also be classified as pre-capillary or post-capillary. Symptoms include exertional chest pain or shortness of breath, abdominal fullness, peripheral edema, jugular venous distension, syncope, or fatigue. Diagnosis is often delayed by several years because of less obvious symptoms. Young adult females are most likely to have the diagnosis overlooked. Testing always includes an echocardiogram and may include pulmonary function testing, high-resolution CT scans, VQ scanning, or polysomnography. Patients with unexplained intermittent dyspnea or shortness of breath and normal echo or pulmonary function testing should be considered to have pulmonary hypertension. Management is with supplemental oxygen, preventing fluid buildup, pulmonary rehabilitation, or referral to a pulmonary hypertension center. Additionally, Group 1 is treated with vasodilators, Group 2 with guideline-directed medical therapy for heart failure, Group 3 with bronchodilators, antifibrotic therapy, or CPAP, Group 4 with anticoagulation, riociguat, or surgery, and Group 5 for underlying conditions. Poor prognostic factors include syncope, right heart failure, venous congestion, and systolic hypotension. The prognosis is worse for Group 3. In summary, this is a deep dive into hypertension. If you want to learn more about hypertension, go to our website, www.healthnetp.com, and you can also book an appointment on healthnetp.com.